Welcome to the deep dive. So, this is your deep dive crafted specifically from the sources you shared with us, those learning objectives, your notes, and the articles on trauma resuscitation.
Exactly. And our goal today really is to slice through all that material and pull out the key stuff. We're digging into the evidence for some, really critical interventions in trauma.
We want to give you that shortcut to understanding the big concepts, the evidence, maybe some surprising bits based purely on what you gave us.
Yeah, make it stick. So looking at your sources, it seems like the main focus is tranexamic acid, TXA, especially in major trauma and TBI.
Good.
We'll definitely be leaning on those scary AH2 and Crash 3 reviews you flagged.
Right, like the Palm Crit and First 10 EM ones.
Yeah.
And your Knights also brought up some really important questions about IV calcium and massive transfusion, permissive hypotension, and that hypertonic saline versus mannitol comparison for head injuries. We need to touch on those too.
Absolutely. We'll spend the most time where your sources gave the most detail, which is definitely TXA, and then we'll cover the other questions as they were presented in your materials.
Okay, great. Let's jump right into the deep dive on TXA then. We know it's an antifibrinolytic agent, helps stabilize clots. Your sources really point to Tarash H2 as like the landmark trial for its use in general trauma.
For sure. CURE-AH2 it was huge, really pragmatic design, over 20,000 adult trauma patients, loads of countries
And
involved.
the criteria were pretty broad, right? Like significant bleeding or even just risk of bleeding
Right.
within 8 hours of the injury.
Exactly. And the intervention was straightforward. TXA, a 1-gram IV load, then another gram infused over 8 hours versus a placebo.
Okay. And the main thing they were looking for.
The primary outcome was in-hospital death by day 28.
And the big headline finding.
A clear reduction in all-cause mortality. It went from 16.0% in the placebo group down to 14.5% with TXA,
Yeah.
so statistically significant. P-value 0.00035.
Okay, so that translates to a number needed to treat, an NNT, of about 67 to save one life. And your sources also highlighted it specifically reduced deaths from bleeding itself.
Yes, death due to bleeding dropped from 5.7% to 4.9%. Significant again.
But here's where it gets a bit counterintuitive based on the critiques in your sources. Despite reducing deaths, especially bleeding deaths, CRHH2 didn't actually show a significant difference in how much blood people needed.
Exactly. No significant difference in the need for transfusion, the total amount transfused, or even the need for surgery.
Which feels weird, right? If you're stopping bleeding, shouldn't you see less blood use?
It does seem weird on the surface.
Yeah.
Your sources brought up some possible explanations like survivorship bias, maybe. Perhaps TXA saved some really severely injured patients who would have needed massive transfusions or surgery but might have died earlier in the placebo group. If they survived because of TXA, they still contribute to the transfusion stats, kind of masking the effect.
That makes sense. It's complicated. And critically, on safety, CIAH2 found no increase in clots, like DVTs or PEs.
Right. The rates were actually slightly lower numerically with TXA, though not significantly different. 1.7% versus 2.0%. So reassuring on that front within the trial itself.
Okay, but your sources didn't just stop there. They raised some points about the trial's methods and limitations. Praise for size, low dropout, good blinding.
Right.
But
Yeah. Concerns about the inclusion criteria, that phrase substantially uncertain, could it have led to some selection bias? Maybe.
and the mix of healthcare system. From very advanced to quite basic, how well does that apply everywhere? Especially since only a tiny fraction, like less than 2%, were in systems like, the US or Canada with rapid advanced care.
That's a key external validity question. And one source also wondered if the placebo mortality rate was maybe a bit high compared to some settings, which could inflate the perceived benefit.
The fragility index was 48, which sounds okay, but then 84 patients were lost to follow-up. Could that have changed things?
Potentially, yeah. If all those lost patients had different outcomes, it could theoretically flip the result, though 48 is still reasonably robust.
And here's a really thought-provoking point from your materials. The dead or dependent outcome, no difference there.
Right. That's a big one. If TXA saves lives, but those extra survivors aren't necessarily having better functional outcomes, well, it makes you ask about the quality of the survival it provides. It's an important nuance.
Definitely. And back to safety for a sec. While Crash 2 didn't find more clots, some critiques pointed out they weren't, actively screening everyone for them.
No, it wasn't a systematic search. And your sources rightly mentioned the MATTERS trial non-randomized combat setting, which did report more clots with TXA. It adds complexity. even if it's not directly comparable apples to apples.
And just looking at in-hospital deaths might miss things like a PE happening after discharge.
True. So lots to consider, but CRASH 2 was still hugely influential. Now, you specifically wanted to dig into TBI, traumatic brain injury. CRASH 2 actually gave us a little clue there.
Oh, right, the sub-study.
Yeah. Exactly. A small group within CRH2, just 270 patients who had TBI. And in that small group, there was a trend not definitive, but a hint towards less hematoma growth, fewer new bleeds, and maybe better survival.
Okay, so that little signal basically paved the way for a much bigger, dedicated study.
Precisely. Which brings us to KRH3. This one was designed from the ground up to look specifically at TXA for TBI.
Got it. So similar setup, big, pragmatic trial.
Yep. Massive again. Double-blind RCT, over 12,000 patients this time, across 175 hospitals, 29 countries. Really global.
And who got in?
Patients with a GCS less than 13 or any intracranial bleed seen on CT. Crucially, they had to be treated within 3 hours of injury. They actually tightened that window from 8 hours during the trial. And importantly, no major extracranial bleeding. This was focused purely on the head injury.
Same TXA dose as before, 1 gram plus 1 gram.
Yeah, same regimen versus saline placebo. And the primary outcome was head injury-related death in the hospital within 28 days.
Okay, drum roll. What did they find? Your sources seem to indicate it was complicated.
Very. The main result showed a really strong trend towards fewer head injury deaths with TXA. Whether you looked at everyone or in a pre-planned analysis excluding the absolute most severe patients like GCS of 3 with blown pupils, the trend was there. But the p-values just missed the traditional 0.05 cutoff for statistical significance, like 0.059 in that key analysis. So technically, based on the primary endpoint alone, it's a negative trial by strict statistical convention.
Ah, okay. But that's not the whole story, is it? Your sources really dug into the subgroup analyses.
And that's where it gets fascinating. The results were starkly different depending on how badly injured the patient was.
How so?
There was a clear benefit, statistically significant reduction in head injury death for patients with less severe injuries. Think GCS 9 to 15, or those whose pupils were still reactive.
Okay, makes sense. But for the really severe group, GCS 3 to 8, or unreactive pupils.
No effect seen. No benefit at all in that group.
Wow. And did timing matter? Getting it faster?
Yes, but only in the milder group. For the mild to moderate injuries, the sooner they got TXA, the better the outcome. But for the most severe group, it didn't matter when they got it within that 3-hour window. The outcome was the same, unfortunately poor.
So this leads to that idea mentioned in your sources where some patients just too sick to benefit.
That seems to be the prevailing interpretation. The overall TBI population in CRASH-3 was actually sicker, higher mortality rate than the TBI patients included back in the CRASH-2 substudy. The thinking is, for the most devastating injuries in CRASH-3, maybe the damage was already too extensive, kind of beyond repair, by just stopping further bleeding. TXA couldn't undo the primary injury.
So those patients kind of diluted the overall result, hiding the benefits seen in the less severe group.
Exactly. But there is evidence TXA was biologically active. Your sources point out that if you look at death within the first 24 hours, TXA did significantly reduce head injury death across the entire population.
Ah, so it was likely reducing early bleeding and hematoma expansion, even if that wasn't enough to save the most severe cases by 28 days.
Precisely. It suggests TXA does reduce the brain injury component, but as one source bluntly put it, it can't raise the dead if the initial injury is just too massive.
Okay, that interpretation makes a lot of sense. What about safety in CRH3? That seems like a key strength, given the numbers.
Absolutely. Over 12,000 patients give you a lot of power to detect side effects, and the results were very reassuring. No signal at all for an increase in adverse events.
Including clots, like PE, DVT, stroke?
None. No increase seen. That's really robust safety data supporting TXA use in the context of TBI.
That's huge. Your sources also mentioned a possible reduction in GI bleeding. Kind of interesting.
Yeah, small signal, not quite significant, but maybe a hint, foreshadowing other TXA trials. Yep. And importantly, regarding disability.
Did it lead to more severely disabled survivors?
No signal of that either, which indirectly is good news. If it reduces death, especially in the less severe group, and doesn't increase severe disability.
It implies it might be increasing survival with good outcomes in that group.
That's the implication, yes. Your sources also noted a meta-analysis bundled with the CRAH3 results, combining multiple TBI studies which also showed a consistent signal favoring TXA.
Okay, so this brings us to what one source called the methodological crux. We have a trial that's technically negative on its main endpoint p-value. Standard practice says you don't usually act on subgroup findings after that.
Right, normally subgroups are just for generating ideas for future research.
But your sources seem to argue that maybe, just maybe, this case is different, that we should look at the subgroups here.
Yes, that's the argument presented. And the reasoning is, well, several points. First, the benefit in the moderately injured group isn't some random finding. It makes biological sense. These are the patients you'd expect to benefit if you stop preventable secondary bleeding.
Okay, plausible.
Second, it wasn't just one small subgroup. It was consistent across several large related subgroups based on severity. Third, the safety data across everyone is incredibly robust. There's very little downside risk apparent.
And it fits the overall picture from CRA, and other trauma data.
Exactly. So the argument is, you use clinical judgment, look at the totality of the evidence, the plausible benefit in defined group, the strong safety profile, the consistency, and maybe you do act on it, even if the single primary endpoint p-value for the whole group missed the mark.
That's a really interesting perspective on interpreting large trials. Your sources also drew a line from CRASH-3 to spontaneous brain bleeds like ICH, mentioning the TICH2 trial.
Yes, TICH2 looked at TXA for spontaneous intracerebral hemorrhage, not trauma. It was technically neutral on its primary outcome, which was functional status later on. But it did show positive secondary results, less hematoma expansion, so less bleeding growth, and reduced mortality early on.
And how does CRASH-3 help interpret TICH2?
Well, CRASH-3 provides massive reassurance about the safety of giving TXA to patients who have bleeding inside the head, even with associated swelling. It helps calm fears about causing clots or seizures in the brain. And it reinforces the idea that TXA probably does help reduce acute bleeding in the brain, supporting the positive secondary findings of TICH2, even if the long-term functional outcome wasn't changed in that specific trial.
And there's maybe more data coming from CRASH-3 on hematoma expansion itself.
Yes, a sub-study analysis is apparently pending, which could strengthen that link even further.
Okay, so pulling it all together on TXA in TBI, based on your sources, the conclusion seems to be it's safe. Giving it within 3 hours reduces head injury death, especially in mild to moderate cases, and sooner is better.
Right. And while the main endpoint was technically negative, the compelling subgroup data and strong safety profile lead many experts, including those cited in your sources, to view it essentially as a positive trial that should inform practice. Treat the treatable, basically.
That really clarifies the TXA picture from your materials, thanks.
Okay, so that wraps up the really detailed dive on TXA from your articles.
Now, your sources also had those other learning objectives, raising key questions. For these next few points, it seems the articles focused more on just asking the question rather than providing the deep comparative evidence like they did for TXA, so we'll reflect that.
Sounds good. Let's address them as posed.
Okay, first up, 5e calcium during massive transfusions. The question posed was simply, why co-administer it?
And your sources correctly point to the citrate in the blood bags. Citrate's the anticoagulant, right? It stops the packed red cells, the PRBCs, from clotting while they're stored.
Okay, standard stuff. But what happens when you give a lot of blood fast?
The patient's liver, which normally clears citrate, just can't keep up with the load. So citrate levels build up in the patient's blood.
And the problem with that is?
Citrate binds calcium, specifically ionized calcium, the active form.
And we need ionized calcium.
Oh, critical stuff. It's absolutely essential for the coagulation cascade to work properly. You need it for clotting. And it's also vital for heart muscle function, cardiac contractility.
So too much citrate, it grabs the calcium levels drop.
And you get impaired clotting right when you need it most, and potentially cardiac instability.
Yeah.
So the why is you give IV calcium during massive transfusion protocols, or MTPs, to basically replace the calcium being bound by the citrate, keeping ionized levels sufficient for clotting and heart function.
Makes perfect sense. Now, your source material also followed up with calcium gluconate versus calcium chloride. Which one and what's the evidence say? But it seems like that was just posed as a question.
That's right. Based on the text you provided, it flagged that as an important clinical question, which form of calcium is better in this situation, but didn't actually present the evidence or give a preferred answer. It's framed as something for you to look into further.
Okay, got it. Next concept from your objectives. Permissive hypotension in trauma. The question was just, what is the concept?
And again, similar situation. Your source material identified this as a key concept in trauma resuscitation, permissive hypotension. But the text provided didn't define it or go into the evidence for or against its use. It's flagged as an important topic.
Right. Something prompted by the source for further exploration. And the last one was about head injuries and managing brain swelling, comparing hypertonic saline, like 3% saline, versus mannitol. The question, what's the evidence and which is preferred?
And same pattern here. Your sources highlighted this as a critical decision point, choosing between these osmotic agents, but didn't actually provide the detailed comparison, the supporting evidence, or state a preference within the material you shared. It's presented as another key question arising from your learning goals.
Okay. So to kind of wrap up this deep dive then, drawing purely from the sources you provided, we got a really thorough look at TXA, navigating the CRSH2 findings in general trauma, the critiques, and then really unpacking CRSD for TBI.
Yeah, digging into that technically negative result, the crucial subgroup findings, the strong safety data, and the whole debate around how to interpret and apply that evidence.
We also clarified the why behind giving high V calcium with massive transfusions, that whole citrate mechanism.
And we acknowledge the important questions your sources raised about permissive hypotension and the choice between hypertonic saline and mannitol, noting that the provided texts pose these questions rather than offering the detailed comparisons for us to dive into today.
I think this dive really shows how looking at the sources, especially complex trial data like CRACE3, isn't just about finding a single p-value. It's about, understanding the nuances, the subgroups, the safety, the debates.
Right, seeing how clinicians have to integrate all these pieces, the statistics, the biology, the context, to make decisions. It's not always black and white.
Exactly. And that actually leads nicely into a final thought for you, building on all this, especially this CRAH3 interpretation discussion from your sources. Given these debates, like how strictly to apply primary endpoints versus compelling subgroup data, and how different trials like TVRI-CH2 add layers, how do clinicians best take findings from these huge pragmatic trials with all their real-world messiness, potential limitations, maybe conflicting signals, and translate that into making the right call for the individual patient right there in front of them?
That's the challenge, isn't it? Integrating population data with individual patient care in real time. Definitely something to keep thinking about.
For sure. Well, that brings us to the end of this deep dive.